Thank you for visiting our poster presentation on congenital and childhood myotonic dystrophy type 1 in the UK. Myotonic dystrophy is the most common form of adult-onset muscular dystrophy. Often quoted as affecting 1 in 8,000 people worldwide, recent studies have estimated a prevalence as high as 1 in 2,100. Symptoms are wide and varied, with the most severe being found in those presenting congenitally and in early childhood. There is an 18-year range for those classed as having childhood-onset DM. People becoming symptomatic within the first few years of life will have a more severe form of the condition than those beginning after puberty. As treatments and clinical care is improving, more children are surviving into adulthood, but there is still limited disease progression data and clinical experience of adults with pediatric onset DM. The aim of this study was to identify the epidemiology and clinical characteristics of DM1 patients within the UK. As a charity, Cure DM raises awareness of and supports patients and families living with myotonic dystrophy. We have particular focus on congenital and childhood onset. An online questionnaire was sent to and completed by patients and caregivers of people in the UK via the Cure DM website, social media and database, and also via email mailouts from the UK DM Patient Registry. The questionnaire remains open and will continue to gather responses from newly diagnosed families. Responses received to date includes 83 congenital and 110 childhood onset myotonic dystrophy patients, most of which documented age upon completing the survey, age at diagnosis, and age at onset of symptoms. Patients provided information on CTG repeats where available, inheritance pattern, current symptoms, and the professionals involved in their ongoing care. DM1 is often described as being most prevalent around the specialist centres the patients attend, rather than where they live in the country. The questionnaire asked for the nearest town to support a more accurate representation of DM1. The map on the left shows a varied scattering of patients around the UK. The mean age of patients with congenital myotonic dystrophy upon completing the questionnaire was 12.9 years. As per the classification of congenital, disease onset was birth, yet average time to diagnosis was 3.2 years. Patients who responded as having childhood onset DM had a mean age of 33 when completing the questionnaire, with age of onset averaging 11.2 years. This cohort also showed a delayed diagnosis of over 10 years from onset of symptoms. Maternal and paternal inheritance differed between congenital and childhood onset. Paternal inheritance of CDM in this cohort is just under 10%, compared to almost 53% for childhood onset. There is also a noted difference between the sex of both cohorts, with almost equal variance in congenital onset, but a bias towards females presenting with childhood onset at 67.3%. Symptoms experienced and specialist care received by congenital and childhood onset DM1 patients is varied. 80% of CDM patients reported speech difficulties, compared to 50% of childhood onset. Both groups reported a high level of gastrointestinal complaints, yet less than half of these reported seeing a gastroenterology specialist. Differences were also seen between the groups for other symptoms more widely associated with DM1, where patients with childhood onset experienced more myotonia in their hands and more excessive daytime sleepiness. Correlation was found between CDM patients and symptoms requiring assistance at school by a special educational needs coordinator or the implementation of an educational healthcare plan. This was significant for diagnosis of autism. Correlation was seen for the congenital cohort who experienced cardiac issues and had pacemakers inserted, with significant findings in those with childhood onset symptoms. Differences between congenital and childhood onset DM1 are reported for walking abilities, speech, communication, cognitive difficulties including diagnosed and non-diagnosed autism. Difficulties are experienced by patients who do not always have a genetic diagnosis, but as treatments are available to aid many symptoms of DM, genetic counselling should be appropriately provided and diagnosis more readily available. Early specialist care is imperative for improving quality of life for patients and caregivers. Ongoing results will support clinical trial design, as well as promoting combined care within clinics and access to support within educational settings and from wider professionals. Acknowledgement and thanks goes to UCLH London, Cure DM trustees and the UK Myotonic Dystrophy Patient Registry for distribution of the questionnaire. Special mention goes to the UK DM1 community for sharing their experiences and supporting the study. Thank you.